So what we learn from this thing, that if a patient has diabetes and CKD, apparently mobile patient, if you are offering this molecule, they are less likely to develop fast hospitalization due to heart failure. They are going to have less new onset heart failure, and they will have more CV benefit. Also, it is irrespective of whether they have a baseline left ventricular hypertrophy in the ECO or ECG or not, and this is very important. So more of these patients who are just silently having an early stage of disease, you can give them the benefit of allowing this medicine. The combination of a SGLT2 inhibitor and a MRA on the top of ACE inhibitor ARB treatment presumably will be giving a better survival benefit in the future, and that's how the kidney and diabetic group also are trying to grow up with some foundation 3 therapy for diabetic kidney disease, and what we are already using these two, and probably more we should use this new molecule which is called Cardiorenal. Now this is the guideline, and the Indian guideline, we need to understand why you need to give this, because of 5 reasons: hospitalization for heart failure reduction, non-fatal MI, cardiovascular death, and end-stage kidney disease, and sustained decline of GFR. All are shown to be beneficial if you are giving this molecule, not in all albuminuric patient, but patient with diabetes with or without CKD and albuminuria. The key point you need to understand very clearly that there are some 5 S when you initiate and maintain this therapy. One is your potassium has to be less than 5, and from 5.5 to 5, these are the zones where you need to be very clear that patient need to be on good dietary restriction and periodic checkup of potassium. How frequently, it's all goes into the individual judgment and your patient profile. If a patient is having significant worsening of renal failure, maybe we have to do it more frequently. If it is not so, a good diet restriction and non-deviation from therapy will prevent from stopping this therapy. You can initiate with a not very robust decrease in GFR up to 25. You can give, and UACR, although it is more than 30, it is written, we have seen in patients who have more than 100 or something, we are using it. And key treatment effect is, importantly, you need to understand 1 in 5 patients develop less worsening of renal failure and heart failure. So this is the crisp, in a nutshell, the thinking about this molecule. And again, this is a molecule for kidney protection. We are not nephrologists. Maybe some nephrologists sitting in the audience or chair can highlight more than me, but what we have understood, not being a nephrologist, also a physician with diabetes and hidden CKD with or without albuminuria, you must initiate this molecule to prevent further jeopardy in all the system. Thank you.